Then from today, in next several days, I'm going to talk about the fracture, especially the hip fracture, because I always specialize in hip fracture because I devise some devices, for example, femoral fracture, the basicervical fracture, and trochanteric fracture. I already devised three type of devices. So, or maybe in the last my visit to the Myanmar, I to donated the first type of my implant, the so-called dual screw. Maybe one or two set is still in your hospital.
Yeah.
So I talk about how I devise this type of implants. So it is quite very basic. I'm sorry. Okay, it's very basic. So because in Japan is a very aged countries. Maybe its average lifespan is around 86 for the female, and 82 or 3 for male. So it is so many elderly patients. So in this aged population, so hip fracture is increasing dramatically. In the 1989, I just became to the orthopedic surgeon. The number is around 53,000. But after that, the number is dramatically increased. 2020, around 8 years, around 200,000. But in the near future, around more than 300,000 patients annually. It is quite a serious problem. So I also a member of Japanese Fracture Society. Just have a look. This is the Japanese Fracture Society for Fracture Repair. Last year, I tried to invite some faculty of this fracture society, but unfortunately, there is not enough time to visit for them. So initial my plan, I invite them to your country in this year, but unfortunately, due to the COVID, it have not. So, maybe in the near future, many Japanese surgeons is interested in the fracture, especially the severe fracture, open fracture, tibial plateau fracture, or so on. So maybe it is very exciting for the Japanese. But the recently in Japan, so high energy fracture is decreasing dramatically. So far, the most popular fracture is the hip fracture because of the elderly patients, elderly people with the minor trauma, seem to fall down, or sometimes without the falling, without trauma, or sometimes to change the diaper. So naskia fracture. So rolling down, change their position. So very fragile bone can make the fracture at the time. It is a quite serious problem. So in the Japanese society, fracture society annual meetings, so many more than 10 sessions is focused on the hip fracture. For example, surgical technique and or prevention on how to manage. There are so many items to discuss. So that today I will focus on the treatment, or today is the classification. Of course, in your country, the hip fracture is very popular, especially for the elderly patient. Is it right? So many fracture
Yes,
patients.
yes.
Maybe it is increasing dramatically. Maybe just your country, maybe another 20 years or 30 years behind. Maybe the fracture rate should be here, but in the near future, in your country also have the very increasing number of the hip fracture.
Yeah.
So you should prepare in this age. So this is the proportion of the femoral neck fracture and the trochanteric fracture. They are the main fracture of the hip. But it is well known the femoral neck fracture is a little bit younger than the trochanteric fracture. The femoral neck fracture, this is my thinking. Femoral neck fracture is caused by osteoporosis, of course. But this fracture kind of fracture is caused by the morphology of the patient. In my impression, the femoral neck fracture, the patient with a femoral neck fracture has the specialized morphology. For example, the patient have the very torsion of the femoral neck or very steep femoral neck, but I can't analyze yet. But on the other hand, trochanteric fracture is caused by truly osteoporosis. So in this hospital, the average age of trochanteric fracture should be the late 80s. It is not rare to the more than 100-year patients. On the contrary, some patients with femoral neck fracture is very young, in the 40s and the 50s. Or maybe I think the cause of femoral neck fracture is different between the trochanteric fracture. Anyway, so maybe the rate of proportion of the femoral neck should be the less than half. Okay, thank you. Please come on. This is very important. How to treat this patient? It is quite different between the femoral neck fracture and trochanteric fracture. It is well known. Maybe the femoral neck fracture in the treatment is controversial. But so far, so many surgeons prefer to select the bipolar or hemiarthroplasty rather than the fixation. But in the trochanteric fracture, the most patients undergo internal fixation using IM rod or CHS, DHS. This is the difference. But even the femoral neck fracture, around 1/3 patient is indication for the internal fixation. But how to select this treatment is very important. Of course, in the trend, there's a pink area is a hemi or bipolar arthroplasty, and this gray area is the internal fixation. In the late 90s, around 80% patient is for the internal fixation. And bipolar or hemiarthroplasty is very, very limited, and the total heavy as well. But after the 2000, and recently, maybe around 70 or 80% is indication hemiarthroplasty is selected. There are some reasons. One reason is the result is very stable because after the internal fixation for femoral fracture, some complication such as cut out or osteonecrosis or some fracture of trochanteric fracture can occur. So this rate should be around 10% for the non-displaced fracture, another 30 or 40% for the displaced fracture. So to avoid the second operation, so it is very natural to select the arthroplasty. Even to the total hip arthroplasty is getting popular because there is some surgeon that worry about the cartilage wear after the hemiarthroplasty, especially for the younger patients. So in Japan, most surgeons prefer to do the total hip arthroplasty for the patient less than 50 or 60 to improve longevity of the arthroplasty. Anyway, it is the worldwide trend to decrease internal fixation, but hemiarthroplasty, to increasing hemiarthroplasty and the total hip arthroplasty. But many surgeons believe that the hemiarthroplasty or total hip arthroplasty is the last operation for the patient. Because the purpose or reason for the select the hemiarthroplasty is to avoid secondary operation due to the complication. Of course, hemiarthroplasty has a very rare complication after the surgery. But even after the hemiarthroplasty, the dislocation is sometimes occur due to the dementia of the patient or the muscle around the hip joint is getting weak after the operation due to the bed rest. Most patients cannot walk after the fracture. They will stay on the bed. That can weaken the muscle around the hip and leg. That can cause dislocation or the severe contracture of the lower legs. So this is another problem. And even after the hemiarthroplasty in Japan, the periprosthetic fracture is a serious problem. After the arthroplasty, some patients fall down during the walking or fall down from the bed. That can cause subtrochanteric fracture or supracondylar fracture and femoral shaft fracture around prosthesis. It is quite difficult to treat, to fix. So it is quite challenging. So I believe the hemiarthroplasty is not the last operation. We always consider the further operation, especially for the periprosthetic fracture. So, yes, so this is the national trend, the world trend. But this is talking about, this is the hands-on pin. Chanta, have you seen this implant? Have you ever seen this one?
Yeah.
Yeah?
I never seen.
Yes, maybe. Maybe it is very special Japanese situation. Many Japanese prefer to use this implant. I don't know the reason. It's quite popular in Japan. But interestingly, no other than Japan and Sweden. This implant is quite rare, not popular. But in Japan and Sweden, it's very, very popular. This is the very smooth pin. In the diameter is this diameter should be around 6.5 or 7 millimeter. It is a very smooth pin. but this pin has a hook. After the insertion of pin, after the reaming, insert the pin and then twist the screw, then this stick hook will come out. Then can prevent the the back out of the spin and the rotation of the femoral head. This basically this implant is designed for the slipped hip epiphysis for the child hip, slip hip to prevent because epiphysis growth plate is here in the childhood. After the slip of the epiphysis, this fixation area is very small. To secure fixation even for the very small area, this stick works very well. But it can also act very well for the elder patient for the permanent neck fracture. So this is basically Dr. Hansson is born in Sweden, the Swedish doctor. Maybe some Japanese surgeon interested in this pin and introduced important in Japan. After that, it's getting popular. So this is most frequently used implant in Japan. But even using this Hanson pin, maybe this is virtually same in the CCHS cannulated screw. The purpose is the same. But as I said before, around 10% for the non-displaced fracture and around 30% of displaced fracture, the complication will occur. How to prevent? So this is the one reason, especially for the displaced fracture, is to increase usage of the bipolar and hemiarthroplasty. Two, how to improve to the clinical results after the femoral neck fracture, because it is increasing in the future. So there is a two way. So one quite easy way is increase the number of the bipolar. So even for the non-displaced fracture, in some hospital, all patients is treated by the bipolar, even for the non-displaced patient, displaced fracture. Because even for the non-displaced fracture, osteonecrosis or secondary dislocation can occur. It is not rare, but some patients need to undergo the secondary operation. To avoid the secondary operation, so it is very natural to select the bipolar as many as possible. But as I said before, the bipolar is not a final operation. Sometimes it's quite frequent in Japan, the secondary fracture after the bipolar. So maybe in Japan, even in my hospital, in average of the one patient is the prosthetic fracture after the IM nail or arthroplasty. So we should remember the bipolar again. The bipolar is not a final operation. Or to improve the fixation. So there are so many implants to fix the femoral neck fracture. So I inspired to develop the femoral neck fracture fixation. So I devised it. So I believe there are three types of fracture. One type is always successful. Maybe this is the Gardens, the stage 1 fracture, and sometimes successful. regarding stage 2 or something of regarding stage 3, and rarely successful. I believe 3 types. So this percentage can change due to the classification on the technique or devices. If the technique and the device improved, this line come down. So many patients can be successful. But to precise classification, if we can use precise classification, we can separate this one. So if this line is very clear, we can easily select the bipolar and fixation. So it is still controversial. It's different among the patient and the surgeon to surgeon. Some surgeon select bipolar for all patients, and some surgeon fix all fracture, even the displaced fracture in the elderly patient. So it need to make clear line between this one and this one and this one and this one. So we should try to the percentage of this one and even this one. So the first is important thing is clear classification of the fracture. Is this is the Japanese guideline to treat the hip fracture. The hip fracture includes 5 types of fracture. The first one is it's quite rare, the femoral head fracture. And the second one is femoral neck fracture between the subcapital to the base of the femoral neck. And third one is basicervical basal neck fracture. It is quite rare, but in Japan, many surgeons focus on this type of fracture. It's because in Japan, the CT is very, very popular. So we can use CT virtually freely. So we can take CT virtually all patients. So using the CT, we can find that this type of fracture is not so rare, more frequent than we think. So type D is a trochanteric fracture, and E is subtrochanteric fracture. So it is very well known. So in Japan, so treat the hip fracture, especially for the trochanteric fracture, to anatomy of this ligaments. In other words, this is a ligamental capsule around the hip is focused on, because type of fracture and the direction of displacement decided by the ligament around the hip, especially for the iliofemoral ligament. So the fracture line is come here inside the ligament and outside the ligament. The type of fracture and the displacement is quite different. So how to stabilize the fracture is very important in relation with the hip ligament. So I will talk after to when I talk about trochanteric fracture. So in the hip, it is very known. There are 2 types of capsule. The one capsule is ligamental capsule. Another word is the ligament, such as the iliofemoral ligament. Then another one is the synovial ligament. This is inside of the hip joint. So this is synovial no, ligamentous capsule is outside of the joint. So basically, this point is different. This is ligamentous capsule inside here, and synovial capsule inside here. If the fracture line comes between the synovial and ligamentous capsule, we call it the basal neck fracture, basicervical fracture. So it is the very famous anatomy for the hip. But even in the knee, it is similar. So carefully observe the knee. We can find two layers of capsule. One is a very thick ligamentous layer, and the inner layer should be the very thin synovial layer. Between two layers, there are a fat tissue layer. So this construction is similar in the hip and knee. Anyway, so the difference of this insertion point of the two layer of the capsule is very different to make the classification between the femoral neck fracture and the basal neck fracture, and the basal neck fracture and trochanteric fracture. Okay, this is the true femoral neck fracture, just below the femoral head and just above the insertion of synovial layer of the capsule. This is the true area of the femoral neck fracture. So this is a very famous, this is maybe many surgeons classified as the Garden stage 1. The Garden stage 5 is incomplete fracture in the impacted, valgus impacted fracture. But sometimes we can see the complete fracture here. But this fracture is the abducted, the valgus and impacted fracture. How do we classify this one? Some surgeons classify this is, if the fracture is here, classified as stage 1. But some surgeons, this is a complete fracture. So it is it is never the stage 1, but not stage 2, because stage 2 is defined by the non-displaced fracture. This fracture is already displaced. So some surgeons classified this type of fracture as Garden stage 3, because displaced, not completely displaced fracture. So it is quite difficult to classify this one. So we can, in Japan, so even MRI we can use freely. So there are so many MRI machines. So some patient complains hip pain, but no fracture in the plain X-ray. Then we send the patient to the MRI machine. Then we can find easily to such kind of fracture. It is only the MRI can detect this fracture, so-called insufficient fracture. It's a very small minor line on the just below the femoral head. So how to classify this one? Stage 1 or stage 2? Or even the bone scintigram. So it also find that this undisplaced fracture, it can be detected using the plain X-ray. So this is a very famous Garden stage classification, stage 1, 2, 3, 4. But it's quite difficult to classify 1 and 2 and 3 and 4. So it is quite difficult to distinguish two types, this one and this one, this one, this one. So someone recommend to classify only the two types of fracture, either non-displaced and displaced fracture. It's quite simple, displaced and displaced, because the operation strategy and operation type were different between non-displaced and displaced, because most surgeons will select the osteo fixation for the non-displaced fracture and the bipolar for the displaced fracture. And this is the Powers classification. It is also famous. It can imply the stability after the operation, after the fixation. If the vertical fracture is easy to dislocate because the body weight can act as a shearing force that can displace the fracture. But sometimes this Powers classification is misunderstanding. The true classification is borderline is 30 degrees and 50 degrees. But in some paper, misunderstand this borderline is 30 degrees and 70 degrees. And some other report the 50 degrees and 70 degrees. What we should correctly understand, the borderline is less than 30 degrees, the type 1, and less than 50 degrees, type 2, and more than 50 degrees will be classified as a type 3. So AO classification is more complicated. So this one, it is quite difficult to how to classify this one. It's we should compare the results after the bone fixation to compare this with fracture here and without fracture here. So after that, we can correctly classify the type of this fracture. If we see the fracture line here, after this fracture, after the fixation, the result is the worse than the fracture without fracture here. So we should classify as another classification. It is not a true garden stage 1. So how about this one? This is a totally compression fracture. So it is difficult to classify. How about this one? This one is to no valgus and varus angulation, but posterior bending type. It is also problematic to classify. So the opinion, the classification will be different among the surgeons because the garden classification never shows how to classify this one and based on the lateral X-ray. Okay, I'm sorry. Time is up. So I will talk the tomorrow after that. But this is quite a basic. Or maybe it is very boring. But again, in Japan, it is very controversial how to classify this one. So because maybe this is a limit of the garden classification. We should classify using another classification system. It is based on the lateral X-ray and how to classify this type, the complete fracture and the valgus fracture, and the total compression fracture. the posterior bending fracture. So maybe this is another type of fracture. Maybe this kind of fracture is a result will be worse than the other type of fracture. Anyway, tomorrow I will continue to talk tomorrow because this Zoom in meeting is limited, only the 40 minutes, because this is a free version. Maybe tomorrow or day after tomorrow, I can talk about why I devised the dual SC. And after that, I will talk about my device IM nail. There are so many implants. So, okay, anyway, thank you for coming. So see you tomorrow. Cheers, Timpate.
Good night.
Timpate, good night. See you tomorrow. Bye.
Bye.
Bye. Good night.